Today, we're focusing on hypercapnic respiratory failure.
Right.
Okay, let's start at the very top. When we talk about respiratory failure, what are the two main branches we need to separate?
So you're primarily distinguishing between hypercapnic respiratory failure and hypoxemic respiratory failure.
And they're managed very differently.
Fundamentally different approaches. You have to know which path you're on from the start.
Okay, so let's define our focus today. Hypercapnic failure, what's the physiological definition?
We're talking about type 2 respiratory failure. The defining feature is a failure to clear carbon dioxide.
So CO2 builds up.
Exactly. It leads to an elevated arterial partial pressure of carbon dioxide, the PaCO2.
And there's a specific number we're looking for.
There is. The value has to be greater than 45 millimeters of mercury.
And the mechanism behind that, what's failing?
It's a failure of the respiratory pump, plain and simple. The system just cannot achieve adequate alveolar ventilation to get that CO2 out.
Got it. So in contrast, what defines hypoxemic respiratory failure?
That's type 1 failure. And the problem there is all about impaired oxygenation.
Low oxygen.
Right. Your arterial partial pressure of oxygen, the PaO2, drops to less than 60 millimeters of mercury.
So just to be crystal clear, type 1 is a gas exchange problem, like a VQ mismatch or a shunt.
Precisely.
But type 2, our focus, is a pump problem.
It's a pump problem. The mechanics are failing.
Let's stick with that pump failure.
Yeah.
What's the fundamental concept behind why the carbon dioxide level rises?
Well, it's actually simple physics, but with huge clinical implications.
Okay.
Hypercapnia happens when the rate of CO2 production in the body, it exceeds the lung's ability to eliminate it. Retention is the core issue.
If ventilation goes down?
CO2 goes up.
So in a clinical setting, this breakdown tends to happen through three main pathways. What are those mechanisms?
Right. You can think of it as 1, reduced minute ventilation, 2, an increase in physiological dead space, and 3, an increase in CO2 production.
And it's often a mix of all three.
Often, yes. One thing leads to another.
Let's break down that first one. Reduced minute ventilation, that seems like the most direct cause.
It is. So minute ventilation is just your tidal volume times your respiratory rate.
How much you breathe in one breath times how many breaths you take.
Exactly. If either of those numbers drops, if you start taking slow, shallow breaths, the amount of air reaching the alveoli just plummets.
What kind of patient does that? What are the big clinical causes here?
You should think about central nervous system depression. This is your classic won't breathe patient.
An overdose, for example.
Yeah. An overdose is a perfect example. Opioids, benzodiazepines, or maybe a brainstem injury that hits the respiratory drive center.
But it's not always central, right?
No, you also see it with peripheral causes. Things like severe respiratory muscle fatigue or weakness from a neuromuscular disorder like myasthenia gravis.
Okay. Now for this second mechanism, increased dead space. This is where I think it gets a bit more complex.
It does, and it's so important for the patients we see every day. Dead space is, it's essentially wasted ventilation.
Air that goes in but doesn't do any work.
Exactly. It doesn't participate in gas exchange. And in conditions like severe COPD, lung damage massively increases this physiological dead space.
So the patient might be moving a decent amount of air in total. Their minute ventilation looks okay, but a lot of it is just wasted.
That's the key.
Yeah.
The effective alveolar ventilation drops and the CO2 starts to climb. The pump is moving, but the pipes are all damaged.
All right. Okay, number 3. Increased carbon dioxide production. This feels like a factor that can get overlooked.
It gets overlooked all the time, but it can absolutely be the thing that tips a compromised patient over the edge.
How so?
Your baseline metabolic rate determines your CO2 production. So any big systemic stressor is going to ramp that up.
Like a fever.
High fever, sepsis, even something as simple as shivering. It all adds to the CO2 load the lungs have to deal with.
And this is also a reminder about nutrition, isn't it?
It's a classic critical care mistake. If you overfeed a patient, especially with a ton of carbohydrates, their respiratory quotient shoots up.
Which means more CO2 production.
Directly. And that can be just enough to overwhelm a patient who's already struggling. It's often that subtle final trigger.
Let's move on to the systemic impact, the downstream effects. The first is obviously on acid-base status. We have to differentiate acute from chronic right away.
We do. When PaCO2 rises quickly, acutely, you immediately get a respiratory acidosis.
How does that happen?
CO2 combines with water, forms carbonic acid, and your blood pH just drops, sometimes severely.
And why is that drop so dangerous in an acute setting?
Because the body's main buffer system, which is renal compensation.
The kidneys retaining bicarbonate.
Right. That takes hours, sometimes days to really get going. So in acute failure, there's no backup. A small rise in PaCO2 can send the pH plummeting below 7.20.
How does that compare to, say, a patient with end-stage COPD who lives with high CO2?
It's a completely different picture. Those chronic patients have a partially compensated acidosis. Their kidneys have already been retaining bicarbonate for a long time.
So their baseline pH is much closer to normal.
Exactly. They might have a PaCO2 of 65, but their pH is 7.34. That compensation is a huge diagnostic clue.
Moving to the cardiovascular system, this isn't just a lung problem, it hits the whole body. What's the initial cardiac response?
Initially, mild to moderate hypercapnia actually stimulates the sympathoadrenal system.
An adrenaline surge.
Yes. You see a rise in catecholamines, which gives you tachycardia, and an increased cardiac output. The patient looks hyperdynamic, flushed.
But that state can't last. What happens when the hypercapnia gets severe and the pH really drops?
Once that pH falls significantly, let's say below 7.15, the direct cardiodepressant effects of the acidosis take over.
So the heart muscle itself is affected.
It is. It overrides that catecholamine drive. You get vasodilation, depressed contractility, and then rapid hemodynamic instability, collapse.
We also see major neurological signs. That's often what brings the patient in. What's behind the confusion and lethargy?
Carbon dioxide is a potent cerebral vasodilator.
It opens up the blood vessels in the brain.
Right. So an elevated PaCO2 increases cerebral blood flow, which can lead to increased intracranial pressure.
And that causes the symptoms.
That's where you get the headaches, the confusion, the asterixis, the flapping tremor, and if it's not stopped, CO2 narcosis, severe drowsiness, coma, and then respiratory arrest.
It's a vicious cycle then.
Yeah.
The body tries to compensate by breathing faster.
It tries. But that increased work of breathing is exhausting. The accessory muscles get strained, they fatigue.
And that fatigue just makes the ventilation worse.
Exactly. Fatigue worsens the hypercapnia, which worsens the acidosis, which further depresses the patient. It spirals downward.
Wait, let's talk about management. There's a really useful conceptual framework. Won't breathe, can't breathe, or won't breathe enough.
It's a great mental shortcut. It helps you target your interventions immediately.
So won't breathe is pretty clear.
That's your CNS depression. Reverse the overdose. Address the brain injury.
And can't breathe.
That's a mechanical problem. You need to fix the bronchospasm in a COPD patient or treat the underlying neuromuscular issue. It's about removing the barrier.
What's the primary management goal here?
The main goal is to restore a safe blood pH. We're usually targeting something above 7.25.
So you might leave the CO2 a little high.
We often do. It's called permissive hypercapnia. If you try to aggressively normalize the CO2 too quickly with a ventilator, you risk causing lung injury from the high pressures.
What's our first-line tool for ventilatory support?
In the right patient, it's non-invasive ventilation, NIV.
What kind of patient is that?
It's highly effective for conditions like a COPD exacerbation or cardiogenic pulmonary edema. It rests the respiratory muscles, improves ventilation, and can help you avoid intubation altogether.
But it doesn't always work. When do you have to move to invasive mechanical ventilation?
You move to intubation if the patient has persistent severe acidosis or if their neurological status is deteriorating quickly.
Or if they can't protect their airway.
Right. If they can't manage their secretions or if they're hemodynamically unstable despite the NIV, it's time to secure the airway and take over their breathing completely.
Let's talk about oxygen. This is a critical point of caution, especially in chronic patients. We need to be specific about the numbers here.
Yes. Oxygen has to be administered very carefully. The big risk is that you can reduce the hypoxic respiratory drive.
The low oxygen signal that keeps some of these patients breathing.
Exactly. And too much oxygen can also worsen VQ mismatch and increase dead space, which makes the CO2 retention spike even higher.
So what is the specific oxygen saturation target we should be aiming for?
It's a narrow window. You want to maintain the oxygen saturation between 88 and 92%.
88 to 92.
That range provides adequate oxygenation without running the high risk of worsening their hypercapnia.
And while we're providing this support, we can't forget the underlying cause.
The ventilator is just a bridge. You have to be treating the trigger at the same time. Bronchodilators for COPD, reversal agents for an overdose, diuretics for fluid overload.
And what about supportive care? What can trip us up?
Avoiding unnecessary sedation is huge. You can easily turn a can't breathe patient into a won't breathe patient with the wrong medication choice.
Makes sense?
And then it's the basics. aggressive secretion clearance, and just constantly monitoring their respiratory rate and effort for any sign of fatigue.
Great. Let's pull this all together.
So to summarize, hypercapnic respiratory failure is about inadequate CO2 clearance. It's driven by either decreased alveolar ventilation, increased dead space, or increased production.
And the management needs to be precise.
Very precise. It's pH-driven ventilatory support with extremely strict caution on your oxygen targets.
So that early recognition of any new metabolic stress is key.
Absolutely. Recognizing that new fever or that new medication or even just the nutritional load that can prevent the entire downward slide. It's